Medicine is not rocket science, it's just a tad harder. I'm actually not joking. Healthcare systems are amongst the most complex organizational structures that we know of. When we think complex, we think NASA or ISRO, but as I said, hospitals can be equally, if not more complex. Complexity is intrinsic and built into the design and fabric of a hospital. So, why is a hospital so complex? Please indulge me as I attempt to argue this point. Complexity in hospital systems originates from an interplay of, I think, 6 key factors that are unique and native to hospitals. Let me outline them and see if I can help give you examples to support them as well. So, what are these 6 factors? Number one, tight interconnectedness. So, think about the relationship between histopathology and surgery and how tightly intercoupled they are. Nonlinearity. Number two, unexpected patient outcomes could be an example. Number three, emergence. There's always an unexpected complication. There's always the possibility of the emergence of an infection that is resistant to all the known antibiotics that we have. There's uncertainty. Number four, diagnostics sometimes can be unclear. Biological responses are molecular and can differ from person to person. Number five, diversity. Think about the wide variety and diversity of patient demographics that visit a hospital. Think about the difference in the staff's expertise. Look at the level of clinical variability even amongst doctors. 6, scalability. The volume, scale, and patient load can vary wildly between departments, between days. These 6 factors are by no means exhaustive, but I just wanted to give you a glimpse into the underlying factors that generate an innumerable number of failure points that exist and can be scattered across a hospital system. I think that complexity, we talk about it, but our relationship to complexity is shallow and superficial. I don't think it is adequately studied. It is suboptimally researched, but such an important area which can drive coordination and congruence if all of us and all the stakeholders in a hospital come together and understand this in a slightly deeper manner. My intention is not to get into the science of complexity, but merely to highlight its role in the dynamics of balancing economics and medicine. Let me now give you a glimpse of what I call the systemic complexity variables in the next slide. The complexity of any system depends on 2 key variables. How many components are part of the system and how interconnected are these components? Based on these 2, we can classify systems falling into 4 quadrants, a simple 2x2 matrix. Quadrant 1, few components and little interconnectedness, simple systems. Quadrant 2, many components and little interconnectedness, complicated systems. Quadrant 3, few components but high interconnectedness, relatively complex. And quadrant 4, many components and high interconnectedness, highly complex. Now, if we were to combine the 6 factors that I listed earlier and verify the level of interconnectedness, hospitals fall into quadrant 4, highly complex systems. Let me cite a few examples to illustrate this. 1. Imagine an elderly patient with multiple comorbidities suffering a severe condition where protocols are unclear or at best iterative. And say such a patient gets afflicted by a hospital-acquired infection and is resistant to most of the known array of antibiotics. Highly complex. Number two, imagine the impact of a flawed pathology report on surgical or medical intervention decisions. Flaws probably due to poor maintenance or calibration of laboratory equipment and instrumentation that the reporting doctor might be unaware of. Number three, imagine errors that could creep into the EMR, electronic medical records, or care plans when used by multiple users and inaccuracies that get generated and creep in during hastily done shift handovers. Another example, 4. Patients with similar medical conditions don't necessarily respond similarly to the same medication or intervention. Most interventions are standards based, but disease and biological responses are molecular. Number 5, there always seems to be a mismatch between the patient and the protocol and the patient and the bed due to multimorbidity and interacting sociocultural influences. Mechanical systems behave linearly. They interact linearly and generally produce results that can be measured and predicted with reasonable accuracy. Additionally, we can generally control the output of a mechanical system by manipulating the input variables. In contrast, complex systems interact nonlinearly, produce unexpected results, and complex system is dynamic. Feedback can vary dramatically with situation and input conditions. And importantly, we have almost no control or very little control to manipulate input conditions and variables in a biological system. A healthcare system comprising networks of divergent components, IPDs, OPDs, imaging, pathology, nursing care, rehabilitation, pharmacy drugs, implants, government regulation, medical legal issues, families, patients, all of these interact non-linearly at widely differing scales, often producing unintended results and consequences like adverse drug reactions, nosocomial infections, rehospitalization, poor functionality, or even financial decline, both for the provider and for the recipient of medical services. Recognition and internalization of the magnitude of this complexity should encourage us to seek adaptive, collaborative, and integrated care models as rational responses. It should incentivize self-reflection, humility, and reflective medicine. Sadly, this doesn't seem to be the case today. What is more common is more management intervention, more policy changes that generally disintegrate into blame gaming and finger pointing. Usually, such interventions seem to worsen the very problems that they were introduced to resolve. Complex systems, I reiterate, do not respond positively to a typical top-down and an aggressive more is better approach.